Welcome everyone to the webinar, One Infection, Four Continents in 8 Countries, the psychosocial implication of COVID-19, presented by the National Collaborating Center for Infectious Diseases. My name is Zishan Kadar, and I'm part of the research team for this project. I'm joined today by our question and answer moderator, Margaret Rivett Brockman, Senior Program Manager, NCCID. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. I would like to acknowledge that NCCID is located on original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dani peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Before we begin, I would like to quickly go over a few housekeeping items first. We are running this webinar through our Zoom platform. This session is being recorded and will be made available later upon request. This session will begin with a 40 minutes presentation followed by a 20 minutes question and answer period. For those watching through Zoom, please submit all presentation related questions to our question and answer Q&A pod, as we are reserving our chat to post important messages for all attendees. You will be able to post your questions anonymously and like other people's questions to push them up in priority. Some questions or comments may be answered privately or temporarily dismissed to move them out of priority. Please send all troubleshooting questions to Shivan Balakumar at umanitoba.ca. We will do our best to assist you. So today's webinar will provide public health practitioners, clinicians, psychologists, and psychiatrists with the information on the mental health challenges at the population level and their behavioral response during this pandemic. In today's presentation, Dr. Melissa Généreux presents an overview of the initial psychosocial health trajectory and behavioral response to the COVID-19 pandemic. Her presentation will cover the epidemiological, psychosocial sequelae of the pandemic across countries based on the reported mental health problems per Diagnostic Statistical Manual-V criteria and coping strategies adopted by survey respondents. Again, please submit questions through Q&A or email at any point during or after the presentation. Without further ado, I would like to introduce our speaker, Dr. Melissa Généreux, Canadian Institute of Health Research Lead, holds a doctorate in medicine, a master's degree in public health, and a specialization in community medicine from the University of Montreal. After having been appointed as Director of Public Health for 6 years in Estrie region, she now acts as a medical advisor both at the regional and provincial level in Quebec. She has developed an expertise in the field of disaster management and psychosocial recovery through her strong involvement during the Lac-Mégantic tragedy in 2013 that destroyed a large part of the downtown area, both as a researcher and as a decision maker, as well as through her support brought to by public health authorities as a consultant during the 2016 Fort McMurray fires in Alberta and the 2017 and 2019 spring floods in Quebec. As a member of the WHO Health Emergency and Disaster Risk Management Framework Research Network, she has developed a strong international network and has contributed to several knowledge creation and translation activities in the field of disaster risk reduction. She's currently leading 2 studies, one on socio-sanitary consequences during and after the 2019 spring floods in Quebec, and another on the psychological and behavioral response to the COVID-19 pandemic. With this, we will start our presentation with a look at the psychosocial implication of the COVID-19, presented by Dr. Melissa Généreux.
Thank you very much, Zishan. And now I'm just going to share my screen. Just give me a second. Okay. So could you just confirm that everything's right with the slides? Yes. Good. Yes. Okay, so let's start. So I'm very happy to be with all of you today. I've been working with all my research team very hard in the past year. It was surely not expected, but we have learned so much, and I'm really proud of everything that we have learned and that we're about to share with you today. So as explained by Zishan, we're going to have the most of the presentation is going to be about what we have observed with regards to psychosocial impacts of the pandemic. And more recently, we have brand new findings about the impacts of the long COVID as well. So that's very interesting and very new, not even published yet. Then we're going to have also a look at what could explain such social impacts, of the pandemic and the COVID. And finally, and maybe more briefly, we're going to have a small discussion about what could we do as public health authorities or even medical professionals to try to put in place some interventions that could reduce these impacts. So let's jump into the first part, psychosocial impacts. So the first thing to know here is that from the very beginning, my research team and I have been considering the pandemic as a disaster. And some of us may be a bit surprised about this fact, but this is really a disaster because you have in front of you the definition of a disaster, which is any kind of event that would disturb the human environment in such a way that it would exceed the capacity of our community to function normally. So I think that given this definition, we're all agreed that the pandemic is really a disaster. But most of us will more recall all the previous disasters that have hit Canada. Maybe the most renowned would be the Lac-Mégantic rail tragedy, the wildfires in Fort McMurray in 2016, the spring floods in 2017 and 2019, that stroke in Quebec, but also elsewhere in Canada, and now the COVID-19 pandemic. And what's very interesting here is that regardless of the type of disasters, we are expecting such waves of emotional reactions. So that would be a mistake to think that it will be at the beginning, like in the weeks or months following the disaster, that we will expect the most adverse emotional reactions. Because in fact, in the first few weeks, we usually assist to what we call our heroic and honeymoon phases. And with regards to the pandemic, it would correspond to, the hashtag, the rainbows and hashtag, it's all going to be good. So in French, ça va bien aller. And I don't know if you noticed, but we don't see that much of these hashtags these days because we're much more in the lower part of the curves, with some disillusionment, some inventory of all the losses and all the stress that we have experienced over the past year, and maybe soon it's going to be years. And then after, we can, of course, expect some kind of reconstruction on the psychosocial aspect, but this is going to take a long time as well, especially since the pandemic seems to be lasting forever. So as opposed to more classic disaster, which usually strike for a few days, and then after we start the recovery phase, here we're still facing the acute phase, but for a whole year, which is quite special. And even also, regardless of the type of disaster, we can expect adverse mental health outcomes. And of course, the post-traumatic stress disorder has been by far the most studied, but one should not forget about a whole bunch of other common problems that could occur, including major depression episode, the generalized anxiety disorder, suicidal thought, substance abuse, somatic symptoms. So the range of psychological disorder can be very wide. And why is so? Because we know that even also, regardless of the type of disasters, that we have to face as citizens primary and secondary stressors. So primary stressors are a bit more recognized. It's all the stressors that come with the crisis. So with regards to the pandemic, we can think of all the stress, the fear of the virus, the confusion, the infodemic, all this overload of information that we have been exposed to, being sometimes true, but something false. So this brings a lot of anger, confusion, stress, fear, all the stigma that we have, that we observe, that maybe that we have victim of, all the losses on the financial part, but also material, and even for some of us, human losses, uh, disruption in access to services, and so on. So a lot of primary stressors during the past year. But one should not forget about the secondary stressors that they will occur as well in the longer term. So once the pandemic is going to be behind us one day, we're going to have to face all these reconstruction efforts on the social and economic sides, for example. We're going to have to face all this exhaustion, so what we call the disaster hangover. So we don't want to hear anything about the pandemic anymore, and we just want to get back to our normal life. And so this is going to bring some kind of a stress at the community level as well. And what's going to happen with all these people that have been isolated for so long, and the low social support that we have suffered from for many of us, the financial problems that are not going to recover just because the virus is behind us, all the social inequalities that have increased over the past year. And I'm also really thinking about the child development and all the school attendance that have been disrupted. So all of this may have long-term consequences as well. And now maybe more recent or emerging information regards the psychological effects of the long COVID as well. So we've been talking about the pandemic as a disaster and all the stress and disruptions that come with it. But in addition of that, the COVID, the virus in itself, as you all know, caused the COVID disease, the acute form of the disease, but it's more and more recognized that the 10 to 20% of the COVID cases may develop more persistent symptoms that can go from fatigue, shortness of breath, headache, loss of smell or taste. But also, it's more and more recognized that some people may develop some cognitive symptoms, like we often hear about the mental fog, the feeling that your ideas are slowed down a bit as opposed to what it used to be before the COVID. And more we hear about anxiety and depressive symptoms that could be much more pronounced in people who have had the COVID previously. So this is like the theory or the basis on which we have developed or study that I'm going to talk about. So this study at the beginning was conceived as a Canadian-led international study. So it has been funded by the Canadian Institutes of Health Research. This is really an interdisciplinary research because we're working with politics sciences, with the communication sciences, and of course, public health sciences. So we have influence each other in such a way that we have had the chance to build a very original, innovative questionnaire, including some questions on communication strategies, the media discourse, the influence of the information we have access to, and ultimately we had the chance to look at the psychological and behavioral response in times of pandemic. So we have three axes in our bigger project, but today I'm going to focus much more on the first axis, which is about the population-based surveys that have been conducted repeatedly to examine the psychosocial impacts and associated factors. So with regards to these surveys, so we're really talking here of cross-sectional surveys as opposed to longitudinal or cohort surveys, repeated over time. The recruitment was through web panels. So of course, we didn't have the time to recruit through a phone-based survey, for example, because we know that such type of surveys can take several weeks and even months. And what we wanted is to, get some pictures, accurate pictures at the various times over the past year. Then the recruitment was in the web panels was attempted to be as representative as possible of the general population. So through social media, specific campaigns to include, hard to reach people, and of course, random recruitment through phone. So this is all the strategies that were used to include people into the web panel. And then from these web panels, what we did is we asked the polling firm to target 1,000 adults per country or region, and to make everything possible to make sure that these adults would be as representative as possible of the general adult population. So of course, we're talking about a non-probability sample, but with quotas with regards to age and sex and language, we were able to make sure that the final sample was really representative of the population. And we also had, of course, weighting variables to, again, add other layer of representativeness to the sample. And all of this was made possible through an online questionnaire lasting about 20 minutes. So we have conducted a lot of surveys over the past year, more than I ever did. So I was talking about the international surveys, which started with a pilot survey in Canada, April 2020, then a first and a second international surveys in 8 countries. So I'm going to show you some data about these 2 international surveys, which were conducted at the end of wave 1 in Canada and in the midst of the wave 2, again in Canada, because it's varying a little bit according to the countries under investigation. And then we had the Quebec surveys, because in addition to the funding from CIHR, we also had the chance to get additional funding from the Ministère de la Santé et des Services Sociaux, donc the Ministry of Health and Social Services, ministry anyway. And so in addition to the previous surveys, we had the chance to collect 3 set of data among the Quebec adult population. So the first one being in September, the second in November, and the third one very recently in the February 2021. And it's also important to note that we had the chance to combine these data in Quebec from September to February, so that we have at the end 20,000 distinct adults. So we made sure that nobody had answered more than once to the 3 phases combined. And this is where we got very interesting data about the effect of the long COVID. Then when I'll talk about the psychological response for the rest of the presentation, I'll mostly refer to these 3 items or outcomes, but we have looked to much more than that. So the 3 main outcomes would be the generalized anxiety disorder. Of course, it's always self-reported. This is based on symptoms that are reported by the participants. And these symptoms are based on diagnosis criteria in the DSM-4. So we use a threshold of 10 or more on the GAD-7 scale, which is a pretty well-known scale. So the same thing applies for major depression episodes. So again, we had 9 symptoms based on the diagnosis criteria, and we used a threshold of 10 or more to determine who would fall into the probable depression category versus others. And finally, we also asked the question, so have you seriously contemplated suicide in the past 12 months, which correspond to what we call suicidal ideation. We have also looked to many risk and protective factors. So I'm not going to name it all, but maybe you can know that they have been categorized into 4 distinct groups. So sociodemographic factors, factors that relate to the pandemic, those that relate to the infodemic, and then all what we call the protective factors, like sense of coherence. I'm going to get back to this concept, social support, sense of belonging. Okay, so let's jump into the findings, because I guess that that's what you're more the most curious about. So this has been already published, and you have all the reference at the end of the presentation. So this is really on the first set of data, international data collected by the end of May and beginning of June. So you can see the 8 countries, Canada, United States, England, Belgium, Switzerland, Hong Kong, Philippines, and New Zealand. So we have like the 2 categories, generalized anxiety depression, GAD, and MD, major depression episode. But we also chose to combine these 2 because we saw that there was a pretty strong overlap between people who were reporting probable anxiety and probable depression. So that's the reason why we chose to combine and to create a new outcome that would be presenting symptoms in line with either GAD or MDE. And this is quite interesting because you can see that by the end of wave one, all around the world, we had something like 30% of the general population, adult population, that was reporting probable anxiety or depression, which is, of course, huge. You can also see that Canada was quite in the middle of the 8 countries under investigation, with England and United States being the most affected. And some of the Asian countries also seem to be a bit more affected. And by contrast, we had like Belgium and Switzerland, which seem to be relatively protected. I mean, there was still 20% of the population showing anxiety or depression, but it was much better than what was observed elsewhere. And then I'm not even sure if I'm allowed to show these figures because it's currently under review. But I mean, with the context of the pandemic, I feel that it's really important to share the data before they get published. So anyway, you see here that with regards to the combined variables, so GAD or major depression episode, you can see that overall in each of the 8 countries, we noted a small increase in level of GAD or MDE, except for United States, where we observed a small decrease. And just to maybe make you smile, we need to remember that between the red and the blue spot, we had what we call the presidential election at the very beginning of November. And we think that this might contribute to increase or improve mental health in the United States, but this is only an hypothesis, of course. But you see that here in Canada and everywhere we had this increase, and overall this is an 8% increase in probable anxiety or depression. And I didn't mention that, but the recruitment strategy, the sampling and everything was exactly the same from the first phase of data collection and the second one. So we really think that this increase is a real increase rather than just a change in the methodology, for example, that could explain the change in the percentage that you see. Then this figure is a bit more complicated, but so interesting, because what we did is that we splitted the data, always the data from November 2020, by age, by sex, and by country, and also by phase of data collection. So the solid circle corresponds to the most recent data, and the hollow circles correspond to data in May or June. And the red circles correspond to women, and the blue ones to men. So basically what we see here is a couple of things. So we see that a woman systematically, with the exception of older people, show even in older people, they show like an increased risk of probable anxiety or depression. But the most striking part is that the young people are showing much more elevated proportion of anxiety and depression than do the older adults. You can also see that this increase over time was much higher in the younger age group than it was for the older age group. So they were already more affected at the beginning of the pandemic, and the deterioration went faster for this age group. So there's something very alarming, I think, for the 18 to 24 years old age group. And you can also see that overall, regardless of the country, but Switzerland, which is a small exception, you can see that every country has a proportion of above 50% of young adults reporting probable anxiety or depression, which is huge. Now, let's get back to the Quebec survey, because I think we had like more recent data that maybe applies a bit more to the current context. Data were, the participants were recruited from February 5 to 16. And you can see that overall, during this small period of time, we had more than 10,000 adults that were recruited, which is pretty good, from all the health regions here in Quebec. And regarding the data, so you can see that when we look at all of Quebec, we see that probable anxiety and probable depression, always based on the same scale that I was talking about earlier, are pretty elevated, so 16%, 20%. But what's the most disturbing is the fact that when we compare these data to the pre-pandemic values based on population-based surveys conducted in Canada or in Quebec in the years previous to the pandemic, we can see that anxiety just jumped to very high levels, as did the probable depression. So, and by the way, the pre-pandemic values for the depression is based on exactly the same scale. So basically, we went from 7% in the adult population to 20%, which is almost 3 times higher than it used to be before the pandemic. And regarding the suicidal ideation, you can also see that it doubled from with regards to the pre-pandemic values. So of course, it's only 6% of the population, but I mean, I shouldn't say only, because 6% of the Quebec population, and it's quite similar in the rest of Canada, by the way, who reported having seriously contemplated suicide over the past 12 months, which is very important. You can also see that urban areas, so the most urban areas would be Montreal, of course, is showing definitely higher proportion of anxiety, depression, and suicidal thought, which would be probably explained by the fact that the stress and the fear of the virus and all the control measures were more intense over there since the very beginning. And what's interesting is that since we have such high levels of anxiety and depression that don't compare to the pre-pandemic situation, we found out that these levels of anxiety and depression are much more similar to the levels that were observed following the Fort McMurray wildfires within the small community 6 months after the fires. So this is quite disturbing again, because we can see that over there 6 months after, 20% of adults were reporting probable anxiety and 15% probable depression. Again, it was based on exactly the same scales as we did. So it's like, we should, in other words, we could say that in Quebec, and this is quite the same thing in the rest of Canada, the situation with regards to mental health is quite similar to that of a community that have been hardly hit by wildfires. So this means a lot. Again, here in Quebec, and it's quite similar in the rest of Canada, we can also see that the difference according to age is very big. So you can see that again in the 18 to 24 years old group, 43% in February in Quebec were reporting probable anxiety or depression, as opposed, for example, to 10% in the 60 years old and older. And I was just wondering, how was it in November as opposed to February? And we saw maybe a small decrease, but this was not a significant decrease. So there's something, you know, the psychological health of the young adults was bad in November, and it was still bad in February, in other words. And then I promised that I would talk about risk and protective factors. So we've been talking a lot about the mental health in young adults, as well as in women that would be more negative. But above these basic sociodemographic factors, what we found out is that you have, like here, the ranking, several factors were also associated with probable anxiety or depression in times of pandemic. So these are again based on data from February in Quebec. So we found out that the sense of loneliness, so those who reported feeling very lonely, were 3 times more likely to report anxiety or depression as opposed to those who feel less lonely. Then the low social support also are much more at risk. Those who report a low sense of coherence, I'm going to get back to this concept. Then those who felt being a victim of a stigma due to the pandemic, can be for with regards to receiving a diagnosis or being in quarantine, or maybe just because they're a health worker of their health worker status, for example. And then the financial losses comes to the 5th place in the descending order of the main factors. And all of these data have been adjusted for a bunch of other confounding variables. So it means that independently of all of the other factors that were under study, these factors were independently associated with either anxiety or depression. Then I'm going to finish the finding parts with the long COVID, because this is like a very recent finding that we made by combining the data from September to February in Quebec. Because by doing so, we were able to get as much as 600 people who reported having received a diagnosis of COVID. So with such a big number, we were able to compare 3 categories. So we had 3 categories of COVID-19 experience. So we would have those who received the diagnosis, those who said that they had an experience of COVID in such a way that they had to be isolated, or they had to experience a quarantine due to contact with a case of COVID, or due to symptoms of COVID without any diagnosis. So these people would have such a smaller experience of COVID, less intense than receiving the diagnosis, but still an experience of COVID. And then the third group, which would be kind of control group, would be the rest of the population who had been exposed to the pandemic like everybody else, but didn't had to experience the COVID, so the virus closely. And what's really interesting here is that, again, we compared the level of anxiety and depression according to these 3 levels of experience of COVID. And what we found out is that with regards to depression, the risk of presenting a probable depression was much higher in the diagnostic group as opposed to the contact or symptoms group, and even more true as opposed to the general population. So in other words, we could say that the people who have been diagnosed with COVID would be about to be twice as likely to be depressed as opposed to the general population. And this doesn't seem to be fully explained by the stress of by the experience of COVID, you know, all the stress, the isolation, the financial loss. Because if this was true, we could expect that the level of depression would be quite the same in the contact or symptom groups as opposed to the diagnosis group, which is the case, for example, for anxiety level, that doesn't seem more elevated in the diagnosis group. Then what we did is that I told you previously that we had 9 different symptoms of depression that were under study. And we looked at each of these single symptoms to see which one would be more closely related to the diagnosis of COVID. So what kind of specific symptoms do people with a previous COVID diagnosis show or report? And what we found out is that it's not the fatigue, it's not the sadness or, you know, loss of interest, like the more classic symptoms that we associate with depression that were specific to the long COVID or people who had a previous experience of COVID, but it was mostly the concentration difficulties or problems, the psychomotor retardation or slowdown, and dark or suicidal thought. And this question is a bit different. So when we're looking at the symptoms of depression, we're specifically asking in the past 2 weeks, and not the past 12 months. So in the past 2 weeks, have you felt that you would be better off, or have you thought or hurting yourself in any other way? So here, what we have is that among those who had a diagnosis of COVID in the past year, as much as 17% reported having dark or suicidal thoughts at least every other day in the past 2 weeks, like frequent. It's not only maybe once in a while, like at least one and every other day they reported such dark thought, which is very disturbing. And you can see that in the general populations, the proportion is much lower, with like 4% of the population reporting such thought. And again, we felt very important to adjust our findings to our associations while taking into account a bunch of confounding factors. So we've been adjusting for the survey phase, age, sex, education, so you can see it at the bottom of the slide, but also pre-existing disease, the perceived threat due to the pandemic, stigma, financial losses, health worker status. So regardless of all of these confounding factors, so independent of these, we can say that if you look at the the line, vertical line, the most at the right, at the right, you can see that it's 1.82, so which means that the risk of likely or probable depression would be 82% increase when compared to the general population, and this is independent of all of the factors that we've been taken into account. So this is really pointing to the biological effect of the COVID rather than the psychological effect of, you know, receiving all the distress that you can feel when you receive such a diagnosis, for example. And if you want to learn more about our work, the NCCID has been very, very generous with our research team by you know, publishing all of our 3 reports directly on their website. So you can find 3 reports based on the data from Quebec, and I think that we also have another web link pointing to the international reports and infographics, which are very cool as well. So you can find everything in French and in English, thanks to the NCCID. So for the rest of the presentation, I'm just going to make a small overview of the recovery. So what can we do in front of all these problems? Because I don't want to leave you on a negative note, but I don't think I'm going to have the time to go through all the slides. So again, I just chose to put more slides than less, but this just don't hesitate to look at them after the presentation, because I won't have time to go through all of them one by one. So I'm just going to go through these ones. So I'm just presenting some key concepts about resilience, but I just want to focus a bit more on these concepts which are more closely related to our research. So, you know, I've been talking about the sense of coherence. So what is the sense of coherence? So why is it so protective against the adverse effect of the pandemic? So we decided to include this concept in our study because sense of coherence is one of the key concepts of a very interesting theory that we call Salutogenesis. It's not that used or popular in Canada and United States as opposed to European countries, but this is a very cool theory which calls for a shift in our analysis of the situation. So rather than focusing on what causes disease, it invites us to focus on what cause or what creates health and well-being, you know. So the thing is that we should stop looking at mental health and just try to dichotomize, you know, in a binary fashion, like you're healed or you're not healed, you're in good health or you're sick, you know. So when we consider or conceptualize well-being and mental health on a continuum, we realize that there's no cutoff and we can always improve our mental health, and we should always try to understand what's going to help us to move to the right side of this continuum. And what researchers have found over time is that the sense of coherence would be really at the core of this very important theory. So they identified like 3 elements that individuals should have as an individual predisposition or individual psychological resources to deal with stress. So these 3 elements would be first, the ability to understand. So when we have to face an adverse situation, and I think this is really the case with the current pandemic, some individuals have a harder time to understand and to analyze all this information so that they can really understand what they have to do, what's happening, what's the cause, you know, having the right information and the right understanding of it. Then the meaning, which is very central. So you can understand everything, but the meaning that you make out of this, you know, the satisfaction in your daily life that you can find back because you just found a meaning that with which you're more comfortable, you know. And then the manageability, so how an individual can feel that he's able to identify and to mobilize available resources to meet demands that are posed by stress. So understand, make sense, and manage. So people who have like these 3 elements pretty well developed are much less prone to develop anxiety and depression the disorders when they have to face stressful situations like the pandemic. So that being said, maybe I just want to end with this, and if you want to ask some questions about other interventions, or you want to go further, just feel free in the question and answer period. But when we had to, as a public health physician in Quebec, we also had to think about how could we conceptualize the recovery model. And I mean, we need to work on it right now. We shouldn't stop by the end of the pandemic to start working on a recovery plan. And what we realize is that the thing we want to avoid is only focusing on specialized services. So some people may think that since we have a lot of psychological disorders, we should have much more psychologists and more psychiatrists in hospitals and clinical settings so that we can meet the demands from the population. But the thing is that it's well demonstrated with the previous disasters that we had to face, for example, the Lac Mégantic train crash, that even though a lot of people are suffering, there's only a small minority of them who will be willing to ask for support. Okay, so we need to have like this community-based approach as well to complete all the specialized mental health services that we can offer. Then the frontline services would be very interesting and important, but not only in clinical setting. So we need to make sure that we have like this community settings or outreach approach in order to detect and intervene early in the process of the disease. And even before people get sick, just working on risk factors, for example, like loneliness. We can have like psychological first aid training that could be offered much more largely to the general population, so that the capacity to detect somebody who's showing some distress signs would be increased, and we would maybe be able to detect and start some interventions with these people, or minimally to refer them to the official services. And then there's all the community approach that aims to promote resilience, strengthen the sense of coherence I was talking about. So there's so many things that we can do and that we're currently working on here in Quebec. So I'm not really aware of what's going on elsewhere in Canada, but one thing I can say is that always based on the salutogenic theory, we had the chance to convince our Ministry of Health and Social Services to invest into a very cool program, which is called the Network of Psychological Health Scouts. Yeah, scouts. So we have like these people that are going to be recruited and trained and attached or working very closely with some health professionals, so that we're going to have like this network in each communities of Quebec. So this is a pretty large investment of almost $20 million yearly. So it's not official, but it might be repeated after a year if it works pretty well. So we're working on this, community approach so that we have a stronger social fabric. And then, of course, we think that the basic services should also take into account the mental health. So, when we're communicating things about COVID, we sometimes should try to focus a bit less on number of case and death and hospitalized people, and focus much more on, the benevolence and how to promote the cohesion and how to put solution forward rather than simply looking at problems, so that people can empower themselves rather than being passive and more considered as a victim of this whole situation. So I'm not going to go over all of these slides because clearly I'm out of my time, but just feel free to look at each of these slides when you'll have more time. So I think I'm gonna stop here, stop sharing the screen, and we'll go with the question and answer period. Oh, yeah, okay.
Thanks very much, Dr. Généreux, for your very interesting presentation. Really fascinating how much you've accomplished in research terms in a very, very short period of time. For those of you who are participating, please at any time enter your questions in the question and answer pod. And we have a few that are listed there, as well as a few that came in elsewhere. So to open up, I'll ask you, can you talk a little bit about how you and your international colleagues respectively interpreted the results you have from each of your countries? Did you see significant, I mean, you mentioned there were differences, but were there different ways that your colleagues interpreted those results for their nation?
Yeah, we were particularly interested in understanding why Belgium and Switzerland were, displaying less severe symptoms of depression and anxiety. So we had this very interesting conversation with them. They said a lot of very interesting things. So, mental health services and including promotion of mental health was a bit more developed when according to their point of view in their respective countries. But they also said that the management of the pandemic crisis was less of a top-down approach. So here in Canada, we have for maybe by province, but each province had like usually a more uniform way of dealing with the situation. And what I understood from Belgium and Switzerland is that they had more flexibility or more bottom-up approach, so that smaller communities were able to determine by themselves how they would like to deal with the control measures, for example. So do we close school or not? Do we, I don't know if it went to the mask and everything, but like all the control measures were determined at a lower level as opposed to the country or provincial levels. So this brought the fact that people were less like their individual liberty was maybe less constrained than what we have experienced, for example, here in Canada. So yeah, that would be an explanation. I don't know if you want to go further, but and I would say in United States, of course, it's a bit more the question of the infodemic. So how could we explain like these alarming data? We really think that this is due to all the mistrust against governments, all the confusion, the false beliefs, all that kind of stuff, which was pretty strong in United States as opposed to other countries like Canada. So it's really like social political factors, cultural factors, media and communication factors. So that's really one thing I retain from all of these precious learnings, is that if we want to understand what's going on in people's head, we need to look at much more factors than like the more classic factors that we're used to in public health. So we need to work with but political science experts, economic experts, communication science experts. And in this way, we're going to be able to understand all these not non-traditional factors that seems to explain a lot in times of pandemic.
Thank you. And I think we'll come back, if we have time, to what you're learning on one of the other axes on media discourse and in the infodemic, as it's now called. One of the questions that has been voted up among the audience members is, by any chance, did you collect data that were specific to Indigenous populations here in Canada, I would say, and then in the other countries?
Yeah, very good question. And I was thinking about this earlier, but we didn't, because I'm not sure we would have enough, an enough large sample so that we could, compare in a really reliable way the Indigenous groups to other people. Because, to make reliable comparison, we like to have a couple of hundreds of people. So, in Canada as a whole, we had overall, for every surveys, we had between 1,000 to 2,000 people. So I'm not sure what's the proportion of Indigenous in the general population in Canada, but I don't know if somebody has this proportion, but I expect it's quite small. So if we apply this proportion to 1,000 people, I don't think we would have had enough participants corresponding to this group to be able to compare them. But we obviously we had some questions about the language spoken, but also the immigrant status. And here we have very interesting findings. So, you know, immigrant or people who weren't born in Canada were showing increased risk of anxiety and depression as opposed to non-immigrant people. So this is not exactly answering to your question, but and the spoken language seems to be a very interesting avenue as well, or something that we need to explore more, because here in Quebec, people speaking English were much more likely to display anxiety and depressive symptoms as opposed to French speaking people. And I didn't talk too much about the difference between Quebec and rest of Canada with regards to anxiety and depression, but overall, with every single surveys that we conducted, people in Quebec overall were showing smaller levels of anxiety and depression as opposed to the rest of Canada. And I don't think that this is really because we're better, you know, or things are going. In fact, I mean, for most of the time, we had like a worse epidemiological situation. But the French speaking, I'm pretty sure that it's playing a major role, and this is maybe why also Belgium and Switzerland are doing better, because when your main language is not English, I emit the hypothesis that your way of getting informed is completely different, you know. So when you speak English, or when you look at media in English, you can look at international media, at the American media, you know, you can have access to any websites. And so the quantity of informations and the risk of being exposed to fake news and to the false information can be huge, and much more than if you stick to your main language. So in French, maybe the possibility of being exposed to fake news is a bit lower. So that's an hypothesis. But sorry, I'm just going away from your original question, but that's all I know.
But it does, I think, point to the value in disaggregating your data as you can to understand some of those nuances.
Yeah.
The next question is, given the very high rates of distress, both anxiety and depression, as well as suicidal ideation in the young people that you've observed, do you think public policy should move quickly to bringing high school students and perhaps college students back into the discussion for into the classroom for in-person learning?
Both in the classroom and in the discussion, because I mean, yeah, of course, in the classroom for sure. We've been advocating for this in Quebec, and because I'm working more specifically in the Eastern Townships, and you know what? We've been the first in the province of Quebec to convince the authorities to accept the reopening of a college. So in Quebec, it's Cégep, but anyways, it's just like after the high school, but before university, so kind of college. And you know, the director of the college in Sherbrooke was really open-minded about reopening the schools, and we just showed all the data about the distress, which was alarming in the young adult age group, and combined with the fact that, you know, we had very good reasons to think that all the control measures were pretty well applied, and we didn't have major outbreaks in college. So, you know, when weighting into the balance between the risk of COVID and the risk, so the biological risk and the psychosocial risk, it was clear to us that the psychosocial risk were way above the biological risk. So we had like this advocacy thing, and they finally, since the beginning of January, they're completely reopened. Not completely, I mean, they had to reduce the density, like the number of students in each classrooms, but at least they just made sure that every student has the chance to go back to school at least 1 or 2 days a week. So this is a pretty good gain. So yeah, I think that our data are very precious to help considering both the virus and other type of threats like psychosocial threats in every single decisions. That has been my main fight over the past year. But you said that maybe it could be good to include the youths into the discussion, and I think that this is clearly not the case actually, or I mean, if it is, I'm not hearing them, or I'm not sure we're giving them such a huge place in the discussion. So, you know, I think it's normal that over the past year we have been in a very top-down approach. Like it's okay, it's the way we manage a crisis and disasters. But after a whole year, I'm not sure that the general population can handle it that much. You know, we need to be empowered to be part of the solution, to be considered, and you know that I don't think we can last with this model a long time. And I think that you could be part of the discussion much more than they are currently.
Thank you. That question about discussion was really my misreading, but good to have. So we think of public health's role in disasters as often being during the preparation and then the response and immediate mitigation. And there's often considered some separation between mental health services and public health. But do you see a role for public health personnel going forward in these longer term responses or assistance to communities to, oh, we've got a slide ready and everything.
Yeah. No, definitively. I mean, all of these learnings, I didn't make them over the past years, just by the way. I was appointed the public health director of the Eastern Townships in 2013, specifically on July 2nd, 2013. And what happened 4 days after that, I've been called in the middle of the night because the Lac Mégantic tragedy just happened, you know. So my whole career of public health director has been largely marked with this very tragic experience. And one thing we realized, not at the very beginning, but maybe in the months following the catastrophe, is that we didn't know at that precise moment what we had to do as a public health organization, but we felt that definitively that the mental health services offered in clinical settings were not meeting the demands or the needs. You know, there was something wrong, because what we did at the beginning is that we just start monitoring. So the first idea of conducting surveys on psychosocial impacts following a disaster came from Lac Mégantic. So I didn't know what to do. So my first reflex was to at least monitor the situation so that I could, you know, validate the fact that the psychological health of the local population was not going that good. And once we started to conduct these community-based surveys 1 year, 2 years, 3 years following the train crash, we quickly realized that the things were bad. You know, a lot of post-traumatic stress, anxiety, depression. So pretty much the same thing as what we're observing currently with the pandemic. Even higher levels, as you can imagine. And then once we were all aware of the psychosocial impacts, everybody was asking me, so what's next? So my first reaction was to, you know, say, maybe we should have more psychologists and psychiatrists. And so, like, you know, the tip of the pyramid I was talking earlier, like the step care model, so the specialized services. And then the year after, things were still as bad as they were the year before. Then we realized that we had to work with the community. So public health, my organization, in a single day to, you know, have this better understanding of what was going on in the community, but not only focusing on problems, but rather.
Unfortunately, we seem to be losing Dr. Généreux in this last part of our webinar.
So it's okay. So anyway, we were very active in, you know, empowering the communities, giving them a voice, helping them to recreate networks and develop a shared understanding of the situation and try to identify potential solutions. And from that very first day of community mobilization, we've been working very closely. We have this outreach team, which works for public health in the community. Every day we have like 3 full-time persons, the social workers, community organizer. So that kind of person who on a daily basis try to identify some initiatives that could help to mobilize the community, to
Well, we apologize for these technical problems just at the end of this webinar, but thank you all for attending, and to Dr. Généreux for her very generous time spent with us. NCCID continues to offer webinars and other information particular to COVID, as well as on other topics. You will find this presentation and the slides available at nccid.ca. And thank you again for joining us this afternoon.
And I'm sorry, I don't know what happened.
Thank you.
Bye.